will focus on an overview of sickle cell disease and the available standard of care in the management of the disease. Our speaker is my colleague and good friend, Dr. Jun Zhao. Dr. Zhao's hometown is Dallas, Texas. She completed undergraduate training at University of Texas in Austin, medical school training at Texas School of Osteopathic Medicine, Fort Worth, Texas, residency in pediatrics at Dell Children's Hospital, Austin, Texas, and came to us highly recommended after completing a fellowship in pediatric hematology and oncology in Phoenix Children's Hospital. Dr. Zhao started at the Norton Children's Institute in September of 2018 and has had a significant impact on our program. Join me in extending a warm welcome to Dr. Zhao. So let's get started. Please take it away, Dr. Zhao.
Thank you for that introduction. I can't see the chat box, so feel free to interrupt me if you have any questions. And please let me know if you have any issues with the sound. I have no relevant disclosures today. The objectives are, today I'll be going over the epidemiology of sickle cell disease. I'll briefly review the genetics and subtypes of sickle cell disease, as well as the overview of the many complications that we see in this patient population. And then I'll go over the treatments that affect, the treatments that are available for these patients. So it is expected that approximately 300,000 people are born every year with sickle cell disease, the majority of which, about 80% of them, are in sub-Saharan Africa. In the United States, there are about 100,000 people living with sickle cell disease currently. In the United States, the sickle cell disease was actually first described in 1910 by Dr. Herrick. He first described the case of severe malaise and anemia in a 20-year-old dental student from Grenada. On examining his peripheral blood smear, he noticed many bizarrely shaped red blood cells, leading him to surmise that the cause of the disease may be some unrecognized change in the red corpuscle itself. About 40 years later, it was discovered that these abnormally shaped hemoglobin is a result of a point mutation on the beta globin that results in the substitution of glutamic acid with valine. As a result, this small change in the amino acid has profound structural and functional consequences. So sickle cell disease is inherited in an autosomal recessive manner, meaning that you have to inherit one mutation from mom and one from dad. And the mutations that you can see for sickle cell disease include homozygosity for the sickle mutation, or commonly referred to as hemoglobin SS disease, compound heterozygosity between the sickle mutation and another mutation that leads to other structural changes, such as hemoglobin C, hemoglobin D, or hemoglobin E disease are also other forms of sickle cell disease, as well as changes that reduce the levels of beta globin production, such as beta thalassemia major or a complete deletion of the beta globin. In patients with African ancestry, the majority of which have hemoglobin SS disease, and accounts for about 60 to 70%. The next most common is hemoglobin SC disease, which is about 30%, followed by hemoglobin S beta thalassemia. The fundamental event that causes the complex pathophysiology and multisystemic consequences of sickle cell disease is the polymerization of hemoglobin S that occurs under low oxygen tension. Polymerization of the deoxygenated hemoglobin S alters the structure and function of the red blood cells. These damaged or sickle-shaped red blood cells are not only less flexible compared to normal hemoglobin, but are also highly adhesive. These repeated cycles of sickling and unsickling shortens the lifespan of these red blood cells. It's about 1/5 to 1/6 of a normal red blood cell lifespan. The outcome of The outcome is the occlusion of red blood cells in almost every organ of the body, and also causes chronic hemolytic anemia, which are the two hallmarks of this disease. On to some common complications of sickle cell disease. It is associated with a broad range of acute and chronic complications. And two patients with the same genotype may also present wildly different. Acute chest syndrome is a common and potentially fatal complication that is particular to sickle cell disease. It's formally defined as a new infiltrate on chest X-ray accompanied by fever and or respiratory symptoms. It's often triggered by infection, an embolic event, or occlusion of pulmonary vasculature. The incidence is most common in children, especially those ages 2 and 4. And the severity of acute chest syndrome increases with age. For adults, if they were to get acute chest syndrome, there is about a 10% of mortality associated with ACS. Pulmonary hypertension has been considered a common complication, but the true incidence is not exactly known. Early estimates thought it was as high as 30%, but more recently, based on studies of patients that underwent right heart catheterization, it is estimated to be about 6%. The rate of the risk of pulmonary hypertension is linked to the rate of hemolysis in a given patient. Pain events affect approximately 60% of patients with sickle cell disease. They can begin as early as 6 months of age when their red blood cells start switching from fetal hemoglobin to adult hemoglobin, and can occur throughout their life. Acute pain events are responsible for about 3/4 of hospitalizations in patients with sickle cell disease, and from the perspective of the patient, they're often the most important and most debilitating. Many of these events can be managed at home with oral pain medication, increased hydration and rest, but in more severe cases, as we're all familiar with, quite a few patients must be admitted to the hospital to achieve adequate pain control. Stroke is the most common and most concerning long-term risk for sickle cell disease. The risk for stroke in children is about 300 times higher. In children with sickle cell, it's about 300 times higher than those without sickle cell disease. And about 25% of adult patients have had a stroke. Silent cerebral infarcts occur in about 27% of patients by age 6, and in about 30% of patients by age 14. The prevalence of silent cerebral infarcts in adults is much less well defined, but it's likely that the progressive injury occurs as the patient ages. Cognitive impairment is much more likely in patients with sickle cell disease as well, about 5 to 9 times as likely. The use of TCDs or transcranial Dopplers and MRIs to screen patients can help to identify patients who would benefit from additional measures to increase the frequency and severity of stroke. Venous thromboembolisms, which includes both DVT and pulmonary embolisms, is increasingly recognized as an important complication of sickle cell disease as well. It occurs because most sickle cell patients are in a hypercoagulable state. By age 30, about 25% of sickle cell patients have had at least one VTE. And the risk for a venous thromboembolism is about 1.5 times higher in patients with sickle cell disease. So in addition, about 15 to 20% of patients develop retinopathy as a result of retinal artery occlusion ischemia, and if left untreated, they will result in loss of visual acuity. For reasons that are poorly understood, patients who have SC disease are actually a higher risk for retinopathy than those with SS disease. Sickle cell disease is also accompanied by severe functional asplenia in the majority of patients, which results in ineffective clearance of encapsulated bacteria and leads to an increased risk of infection, particularly young children. In addition, acute splenic sequestration is also potentially a fatal complication of sickle cell disease. Splenic enlargement is accompanied by hypovolemia and rapid fall in hemoglobin levels. Other anemic events may occur in patients with sickle cell disease that occur in sickle cell disease include aplastic crisis that are associated with acute viral illnesses such as parvovirus. Acute vascular necrosis of bone is seen about 20 to up to 50% of patients and is the result of vaso-occlusion, tissue hypoxia, and subsequent localized osteonecrosis. In addition, about 20% of adults will develop leg ulcers, primarily in areas with less subcutaneous fat or thin skin as a result of AV shunting that deprives the skin of oxygen. It's often accompanied by local insult to the tissue, such as trauma. The kidney is also at particular risk in sickle cell disease. In fact, nephropathy begins as early as infancy with impaired urine concentration, with impaired ability to concentrate urine, and impaired glomerular hyperfiltration. Up to 60% of patients will develop chronic kidney disease, and about 18% will end up with end-stage renal disease and require dialysis or possibly renal transplantation. Up to 35% of men with sickle cell disease will experience ischemic priapism as a result of obstruction of venous drainage with the potential for permanent erectile dysfunction. In addition, hypogonadism and short stature are increasingly recognized as potential complications of sickle cell disease as well. And last but not least, chronic hemolysis seen in these patients will lead to cholelithiasis and possibly biliary obstruction, with about 20% of patients who present with acute pain will require removal of their gallbladder. So insight into the pathophysiology of sickle cell disease has allowed for different targets for intervention and can be summarized in these four categories on the right. So I'll first start by talking about targeting inflammation. So chronic activation of platelets, neutrophils, monocytes, and the endothelium and coagulation factors all participate in this perpetual cycle that causes inflammation. Prior studies looking at IVIG and statins, there have been prior studies looking at IVIG and statin and their effects on neutrophil and monocyte adhesion. Most recently, simvastatin was noted to reduce WBC adhesion. Of course, these were also in patients who were taking hydroxyurea, and it was found that it did decrease the number of pain crises. In addition to activation of neutrophils and monocytes, coagulation factors are also activated. A previous study in the 60s looked at vitamin K antagonists. A small cohort of patients received warfarin for about anywhere from 12 to 34 months. It did show a slight decrease in VOCs, or vaso-occlusive crises. Newer studies had a hard time accruing patients. Heparins have been looked at previously as well, based on its anti-adhesive, anticoagulation effects. The results of those studies have been a limited number of patients and limited results. Direct thrombin and factor 10 inhibitors have also been looked at. Factor 10 inhibition demonstrated a decrease in vascular inflammation that was measured by lower interleukin 6 levels. Although thrombin had no effect on interleukin 6, it was a significant factor for neutrophil infiltration and further inflammation. A retrospective analysis of rivaroxaban, or Xarelto, a factor 10 inhibitor, demonstrated non-inferiority with regard to thrombosis compared to warfarin, with the advantages of less outpatient visits and less monitoring required. Currently, there are 2 treatment phase clinical trials with rivaroxaban. on the pathology of sickle cell disease, but the results have not been published. Patients with sickle cell disease also have increased platelet levels at baseline, and that are further activated during acute vaso-occlusive events. Platelet activation triggers further leukocyte adhesion, or leukocyte activation and red cell adhesion. Antiplatelet therapy with clopidogrel in patients have been studied, but the results were disappointing. And newer third generation drugs have been looked at as well, but unfortunately, the results did not show a reduction in the frequency of vaso-occlusive crises. So in addition to those medications, L-glutamine, or Indari, was studied and obtained FDA approval in 2017. It's approved for patients with sickle cell disease aged 5 years and older. The mechanism is thought to be an indirect action that reduces the oxidative damage by sickled red blood cells. A phase 3 clinical trial showed that the use of L-glutamine led to a 25% reduction in the frequency of pain crises and a 33% decrease in hospitalization rates. And the drug was reported to be safe and well tolerated. In clinical practice, it's been harder to catch on, mainly because of the taste, and it's rather expensive. There are over-the-counter forms of Indari or L-glutamine as well, but the actual concentration or the active component is not FDA regulated. So the second class or group of drugs to look at are those that are targeting vaso-occlusion, specifically those that affect adhesion between the cells and the endothelium. So Adaptio or crizanlizumab. Going forward, I'll refer to it as Adaptio mainly because it's easier to pronounce. It is a monoclonal antibody to a P-selectin and blocks the adhesion of activated erythrocytes, neutrophils, and platelets. It was evaluated both alone and in combination with hydroxyurea therapy for prevention of sickle cell-related pain crises. In this double-blind, randomized, placebo-controlled phase 2 trial, participants who were receiving hydroxyurea as well as those not receiving hydrea were randomly allocated to treatment with Adaptio in the low-dose group at 2.5 milligrams per kilo per dose, and the high-dose group, which was double the dose. In addition, there was a placebo group as well. The medicine was administered IV 14 times over the course of a year. The primary endpoint was the annual rate of sickle cell-related pain crises among those receiving high-dose therapy versus placebo. The trial enrolled a total of 198 patients. Among patients who received high-dose Adaptio, the median rate of crises per year was about 45% lower, falling from about 3 per year in the placebo group to 1.6 per year in the Adaptio group. High-dose Adaptio also significantly increased the time to first crisis to 4 months from about 1.38 months. Of note, crisis events were reduced both among those receiving hydrea and those not receiving hydroxyurea. Serious adverse events were reported at the same rate in the high-dose Adaptio group and the placebo group. The common side effects, or the more common side effects that occurred in about greater than 10% of the patients, included arthralgias, diarrhea, pruritus, vomiting, and chest pain. There was a reported case of a patient that experienced intracranial hemorrhage, but he did not die from that. There was some concerns about the effect of platelet adhesion due to disruption of platelet adhesion by blocking P-selectin. So next generation agents that block P-selectin designed to improve safety and duration of action are in clinical development currently. And this medicine has been approved for patients aged 16 years and older. So in addition to targeting inflammation and vaso-occlusion, there are medicines that specifically target hemoglobin S polymerization. The first one, and the one that we all know the best probably, is hydroxyurea. The medicine was first approved by the FDA in 1998 to reduce frequency of painful crises and to reduce the need for blood transfusions in adults with homozygous SC disease. Hydroxyurea is a ribonucleoside diphosphate reductase inhibitor that was first used in myeloproliferative disease, and its mechanism in sickle cell is multifactorial. The exact mechanism is not known, but it does certainly increase the production of fetal hemoglobin. While the properties of fetal hemoglobin are somewhat different from those of adult hemoglobin, incorporation of hemoglobin F into normal adult RBCs is not associated with functional impairment. Some patients with sickle cell disease have naturally high levels of hemoglobin, and that's thought to be a protective measure. The efficacy and safety of hydroxyurea for treatment in adults was evaluated in a double-blind, randomized clinical trial. Patients who have had greater than 3 pain crises per year were randomly allocated to the hydroxyurea group or the placebo group. The trial was halted after about 21 months because those patients who received hydroxyurea experienced 2.5 crises per year compared to those who were in the placebo group, who had about 4.5 crises per year. Among patients assigned to hydroxyurea, both times to first crises and second crises were longer, and fewer patients who received hydroxyurea required transfusions. A long-term analysis conducted in adult patients who had received up to 9 years of treatment found that hydroxyurea was associated with a significant, or about a 40% reduction in mortality. Evidence supporting the use of hydroxyurea in children came from the Baby Hug and the European Sickle Cell Disease Cohort Hydroxyurea study. In the placebo-controlled Baby Hug trial, hydroxyurea was associated with a statistically significant reduction in the rates of initial and recurrent episodes of pain, dactylitis, acute chest syndrome, and hospitalization. In the European study, the rate of VOC episodes reduced from 2 in the 12 months prior to 0 during the 12 months of treatment. And the number of hospitalizations were reduced from 2 to 0 in the same time frame. Both of these data of hydroxyurea in pediatric patients in 2017. So in addition to the Baby Hug trial, there was the Twitch trial that concluded that that basically switched patients on prophylactic transfusions to hydroxyurea, and that hydroxyurea was comparable for primary stroke prevention. However, in patients who had a prior stroke, switching to hydroxyurea was not comparable for secondary stroke prevention. And most recently, there's been publications showing that hydroxyurea has been safely used in sub-Saharan Africa as well. And these are peripheral blood smears that show the improvement in the red blood cells, improvement in hemoglobin levels, as well as the shape of red blood cells during the course of treatment. As you can see, the MCV does go up fairly significantly, and the average hemoglobin level increased by about 2.5. The evidence that hydroxyurea benefits children and adults is overwhelming. Unfortunately, multiple barriers still exist to its use in patients with sickle cell disease, and studies have found that adherence to hydroxyurea can be poor. Adverse events, which include alopecia, nail discoloration, headache, nausea, as well as the need for frequent blood draws, have negative impact on initiation and long-term adherence to the medicine. In addition, hydroxyurea is potentially carcinogenic, although there's been no data to show the increase of malignancy. And in addition, it can be a teratogen and can affect fertility. The next medicine I'll discuss is voxelotor or Oxbrida. This medicine obtained FDA approval in November of 2019 for adults and children aged 12 and older. The drug was studied in patients both with and without hydroxyurea. The drug directly targets hemoglobin S polymerization by forming a reversible covalent bond with the N-terminal valine of the alpha chain of hemoglobin. This changes the conformation of hemoglobin in a manner that increases affinity for oxygen, reduces the amount of deoxygenated hemoglobin S for polymerization. The efficacy of Oxbrida was assessed initially in a phase 1-2 randomized double-blind placebo-controlled trial with healthy adult volunteers and in patients with sickle cell disease. It was followed by a single-arm open-label extension study. A total of 38 patients with sickle cell disease received Oxbrida at doses of 500, 700, and 1,000 milligrams per day or a placebo for about a month. And 16 patients received doses at 700 or 900 milligrams or placebo for 90 days for a longer period of time. No sickle cell crises occurred during treatment, and improvement in surrogate markers of hemolysis were seen. They noted increased hemoglobin levels induced hemolysis and a decline in the percentage of sickled red blood cells. After just 2 weeks of treatment, all doses of Oxbrida were associated with increase in median hemoglobin levels and a reduction in clinical laboratory markers of hemolysis. These improvements persisted through 6 months of treatment with a median increase in hemoglobin by about 1 gram per deciliter, and greater than 50% of patients achieving an increase in hemoglobin from baseline regardless of hydroxyurea use. On the basis of these results, a phase 3 trial of Oxbrida was initiated in patients with sickle cell disease, and the HOPE, or the hemoglobin oxygen affinity modulation to inhibit hemoglobin S polymerization trial, 274 patients aged 12 and older with hemoglobin levels from 5.5 to 10.5, and with 1 to 10 vaso-occlusive crises in the previous year were randomly allocated to Oxbrida, 1,500 milligrams, 900 milligrams, or placebo. Approximately two-thirds of these patients were taking hydroxyurea as well. So as you can tell, the hemoglobin increased by about 1 gram per deciliter, about 50% of those patients, and fewer vaso-occlusive crises were observed, although it was not statistically significant. And again, this shows the peripheral smear of a 28-year-old woman with sickle cell disease and the changes in her and the amount of sickled red blood cells. And the last area of treatment is changing the genotype in patients with sickle cell disease. And so modifying the genotype, one method includes allogeneic bone marrow transplant. The use of bone marrow transplant was initially reported in the 80s in an 8-year-old with hemoglobin SS disease who also developed AML. She received a matched donor transplant from her sister, who was actually a sickle cell carrier. After her transplant, she was cured from her sickle cell disease. She was cured from her leukemia, as well as all the symptoms of her sickle cell disease had improved as well. Hematopoietic stem cell transplant is now an important therapeutic option for patients with sickle cell disease. There are about 35 clinical trials studying allogeneic BMT in patients with sickle cell. The best data we have are for those with good the matched sibling donor, and currently it is the only established curative therapy. Of course, transplant is very risky, and currently in the United States, less than 15% of patients with sickle cell disease have an HLA matched sibling donor. This chart describes indications for transplant depending on the donor availability. Promising alternative donor sources, such as haploidentical family members, are being studied. There are also studies looking at the balance of the prep regimen used, whether it's myeloablative versus reduced intensity. As new transplant modalities emerge with less transplant-related mortality, better immune modulators to prevent GVHD, and less graft rejection. So accepted indications for transplant have become less restrictive. And transplant in sickle cell disease can be a whole talk itself, so I won't go into the minutia of all of that. In addition to allogenic bone marrow transplant, there's gene therapy. Very broadly speaking, gene therapy involves harvesting of patients' own stem cells, transducing those stem cells with a functional beta globin gene, and reinfusing those stem cells into the patient. This time there's two promising methods for transduction. One is the use of a lentiviral vector-based strategy. The patient's stem cells are transduced with an anti-sickling beta globin variant, which is the Bluebird trial. And then another viral vector-based strategy is using a modified short hairpin RNA to downregulate the expression of BCL11A. BCL11A is a repressor gene that inhibits the expression of fetal hemoglobin. So the thought is by downregulating that gene, you are inducing hemoglobin F. In addition, the other method is using CRISPR, or quote-unquote gene editing, to induce fetal globin by acting on the BCL11A gene. Although different gene strategies have reached clinical trials and the results are promising thus far, they're very much in the early phase of development. And in fact, this year, in February, there was a patient in the Bluebird Bio trial that developed AML. And previously, there was another patient that had developed MDS. And so there was actually so the FDA placed a halt in gene therapy. On further analysis, it does not seem that the patient developed AML as a result of their gene therapy. One of the biggest concerns about gene therapy is the theoretical risk of insertional mutagenesis due to semi-random integration into the genome. And hopefully by this summer, those trials can resume. Those gene therapy trials can resume. So this graph shows the increased life expectancy in patients of sickle cell disease. As you can see, since the 1980s, mid-80s, 90s, the life expectancy has increased dramatically, mainly with the use of hydroxyurea, as well as prophylactic antibiotics and national screening for sickle cell disease. However, the overall life expectancy for patients with sickle cell disease is still about 20 to 30 years behind the general population. And this graph indicates or shows compares the advances in sickle cell disease treatment 100 years from 1910 to 2010, the 100 years prior compared to the past 10 years. So as you can see, there's been a lot of progress made, and it'll be exciting to see what kind of advances will happen in the next 10 years. I also wanted to give a shout out to the pediatric sickle cell team. And with that, I'm happy to answer any questions. And here are my sources.
Thank you, Dr. Zhao, for a comprehensive presentation. There are some questions on the chat box if you would like to look at them, mainly from Dr. Schickler.
Sure. disease. Interleukin-1 beta is increased in sickle cell, especially stroke, and statins inhibit production of IL-1 beta. Does altering pH help with oxygen delivery when hemoglobin is increased? That's a very good question.
Yeah, I was wondering if shifting the pH alters the oxygen dissociation curve so you get better oxygen delivery with fetal hemoglobin being more avid for retaining oxygen.
Yes, it does. I don't know of any studies that are looking at that to answer if that answers your question.
If I may say that there are clinical trials underway for evaluating the role of statins in sickle cell disease and looking at the pro-inflammatory marker, including IL-1 beta, as you have pointed out. And yes, at higher pH, the effect of 2,3-DPG decreases greatly on the hemoglobins. 2,3-DPG binding, that increases oxygen affinity to fetal hemoglobin. So when the levels go down, the effect for fetal hemoglobin is decreased. So particularly happens at pH in the higher than 8. Then usually in the 7 to 8 range, not so much, but greater than 8 it happens.
Thank you, Dr. Raj.
I have a question / comment. It's a step. You talked about the tour Oxbrida and how it decreases markers of hemolysis and increases hemoglobin, and you mentioned that there's no statistically significant reduction in, say, pain crises or clinically significant sort of events. Do you think the thought is that, oh, well, if we have more data, we might be able to use it? Is there a trend towards significance? Is that something that maybe we should stay tuned to hear more about?
Yes, most definitely. There are ongoing trials with Oxbrida. And in addition, the thought is that increasing hemoglobin, the average hemoglobin level itself, can help mitigate a lot of the complications of sickle cell, especially stroke.
Okay, thank you.
So the issue that hasn't been addressed and is certainly not a hematology issue is the social justice issue, and I think that increase in improvement of life expectancy, I think, has a lot to do with hopefully a growing awareness at medical centers in a more equitable treatment of people who previously had not been well treated or ignored. And I think credit goes to our division and our program for the strides that have been made under Dr. Raj's leadership in making sure that our patients, who typically are not Caucasian, get ideal treatment and don't get anchored into having assumptions made when they show up that, oh, this is just another person who we disregard or don't treat regularly, or we get anchored into thinking that everything is just based on their social status, or it's just based on their sickle cell disease. So they get good comprehensive care, and I think that's why our statistics here have improved so much. And I think that credit needs to be acknowledged.
Yes, I couldn't agree more. Dr. Raj has done a lot for our sickle cell population. And I haven't even talked about the apheresis program that we have here, so there's quite a bit.
Yeah, thank you, Ken, for the kind words. I just wanted to say that, it's a team effort, and we have a great team of providers as well as, transition coordinators and also psychologists. So we are currently in two major federal grants, HRSA grant and PCORI grant, and both these elements are looking at improving the lives of sickle cell patients after their transition beyond the pediatric age group. So we have a very unique model, where we have a triad model where there is the provider, the patient, as well as a community-based organization. So we call that the CBO, and our community-based organization is the Sickle Cell Association of Kentuckiana. And this triad model works, it's very unique, and we are trying our best to keep the patients within the medical system after their transition to the adult side. As you rightly pointed out, Ken, our morbidity and mortality rates are very low on the pediatric side, but we want to still continue that high quality on the adult side. And so we have a great partner in Dr. Glisson and Danielle on the Norton Cancer Institute side who are partnering with us and trying to maintain this transition. And so a lot of work has been done, and it's again great credit to the wonderful team I have working together. We want to make it even better and stronger, and clearly we have a lot of visibility in the country too as one of the leading programs in the country. So everybody, thank you for all being part of our team.
Agreed. Dr. Raj and so many in our group really deserve recognition for really being so aggressive with trying to improve outcomes in our patients. Ken, thank you for bringing up this point, because I think it's so interesting, and you're absolutely right. June showed how the average lifespan is continuing to increase, and we hope that there are changes that continue that trend. However, I think there are a lot of factors potentially implicated in outcomes in sickle cell patients, especially like Dr. Raj mentioned, adult sickle cell patients, access to care, insurance coverage, and issues within the medical system. I think all of these potentially play a factor. I think it's also worth noting that the amount of research, money, and advocacy groups, when you say compare sickle cell disease to maybe, say, for example, hemophilia, I think it's important to sort of note that I think there's room for more improvement there and more attention on this disease and finding a way to improve outcomes.
Any other questions? Thank you, Dr. Boland. You're welcome. All right, if there are no other questions, I'll go ahead and log off.
Yeah, thank you all for coming today. I really appreciate it. Thank you all.